Get it for hugs. Get it for haircuts, for birthdays and birthday cakes, for family photos and dreams come true. Get it for holding hands, live shows, and movie magic. Get it for prom night and slow dances, for drinks, dessert, and everything in between. For the friends who become family. Get it for big swings, big adventures, and the biggest days of your life.
At Torrey Pines Bank, our local team of business banking professionals help businesses of all sizes reach their goals. Bank on accountability with Torrey Pines Bank, a division of Western Alliance Bank, member FDIC.
No more backward thinking, time for thinking ahead. The world has changed so very much from what it used to be. There's so much hatred, war and poverty. Wake up all the teachers, time to teach a new way. Maybe then they'll listen to what you have to say. They're the ones who's coming up, and the world is in their hands. When you teach the children, teach them the very best you can. The world won't get no better if we just let it be. Na 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 na. The world won't get no better. We gotta change it now, just you and me. Wake up all the doctors, make the
Good morning and welcome to the CDU Leadership Summit on Health Equity and Social Justice. To our speakers and panelists, including our esteemed keynote speaker, to our sponsors, and to everyone in our CDU family, our Board of Trustees, faculty, staff, students, our alumni, friends, supporters, and guests, I extend to you all a most sincere welcome and thank you for joining us for the second installment of our virtual Leadership Summit, co-presented by Blue Shield California Promise Health Plan and Deloitte. The CDU Leadership Summit in Health Equity and Social Justice is a four-part quarterly series where we align leaders in the health, education, social justice, corporate, and philanthropy sectors to identify inequities affecting people of color and to introduce strategies to address them. Today's discussion topic, Racism as a Public Health Issue, brings together noted local and national leaders to discuss how the pervasive nature of racism profoundly affects not just social outcomes, but health outcomes for communities of color in the United States as well. The COVID-19 pandemic, in conjunction with the rise in social justice movements over the past year, has brought the phrase, racism is a public health crisis, to prominence as more Americans develop intolerance for the long-standing structural and racial inequities that have been in place for centuries. For those who may not be as familiar with the refrain, I'll explain how racism threatens and undermines public health at every turn, particularly in communities of color. But first, we have to define a few terms. Public health is defined as the science of protecting the safety and improving the health of entire populations through education, policymaking, and research for disease and injury prevention. It differs from medicine in that medicine is a more localized science concerned with directly diagnosing and administering care to individuals. Structural racism refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. These patterns and practices in turn reinforce discriminatory beliefs, values, and distribution of resources. At last month's Kickoff Summit event with the prolific Dr. Angela Davis, she astutely noted that attempts to address racism through the sole act of inviting previously marginalized individuals into the fold are noble, but insufficient. Instead, she urged us, particularly those of us in high-ranking positions, to challenge ourselves in critically assessing which aspects of our institutions, if any, may be inadvertently replicating and perpetuating these harmful structures to begin with. CDU has been at the forefront of addressing racism as a public health issue long before it became a talking point for the rest of the nation. And our curriculum empowers our graduates with the language and skills necessary to identify, describe, and most importantly, address the racialized outcomes and disparities they invariably witness as practitioners. I'm looking forward to this morning's discussion with our panelists, all of whom are noted leaders in leveling the playing field and addressing health equity in the state of California and beyond. With this background, I'd now like to introduce Monica Suarez, Managing Director, Public, Nonprofit, and Affordable Housing Finance of Western Alliance Torrey Pines Bank, a longtime and valued partner of CDU, to offer remarks.
Thank you, Dr. Carlisle. Good morning. And as Dr. Carlisle mentioned, the COVID-19 pandemic has put a spotlight on the issues of healthcare disparities and health equity that CDU has been focused on since its inception. And the ability to bring up these issues of the long-standing structural racism that's been built into our system through this leadership summit has been very important, and we are very pleased to be a sponsor of these quarterly summits and these conversations in our community. We look forward to today's discussion. Thank you.
I'd now like to introduce Dr. Susan Fleischman, Chief Medical Officer of Blue Shield, California, to offer remarks and introduce our keynote speaker. Susan.
Thank you, Dr. Carlisle. It's an honor to be here with all of you today, and good morning. I wish that we could be together in person. At Blue Shield of California, we are committed to working hard to transform and bridge the gaps that so many of our members face, but we want to go beyond impacting our members. We want to be a part of addressing the structural racism that Dr. Carlisle mentioned. The healthcare sector alone is not going to be able to fix or change the public health crisis that we are currently in. It's going to take all of us. And there's no better time than now for everyone to lean in. The healthcare system, state and local policymakers, community-based organizations, all of us. That's what it's going to take to close the gaps. And with that, I have the privilege and excitement of introducing our guest speaker, Dr. David Satcher, who I've been a fan of for many years. Dr. Satcher is a physician scientist and public health administrator. He has an extensive record of leadership, research, and importantly for this work, community engagement. He's Phi Beta Kappa graduate of Morehouse College, and non-surprisingly, an Alpha Omega Alpha graduate of Western Reserve University for his MD. He served as the 16th Surgeon General of the United States from 1982 to 2002, and was the 10th Assistant Secretary in the Health Department, the Department of Health and Human Services. He has directed the Centers for Disease Control and been administrator for the Agency of Toxic Substances and Disease Registry. And if that is not enough, Dr. Satcher has also held top leader positions at the Charles Drew University of Medicine, Meharry Medical College, and the Morehouse School of Medicine. He's received 50 honorary degrees and numerous awards from diverse organizations and agencies. And because he's still at it, he is currently the founding director and senior advisor for the Satcher Health Leadership Institute at the Morehouse School of Medicine in Atlanta, Georgia. So ladies and gentlemen, we can't clap out loud, but please join me in welcoming Dr. David Satcher.
Well, thank you very much for that very kind introduction. I can't say how much it means to me to be back at the Charles Drew University of Medicine and Science. It's so much a part of who I am and my sort of upbringing until I always feel good about the opportunity to return, even though this time it's a virtual return. Bring you greetings from the Morehouse School of Medicine. And I am, in fact, sitting in my office at the Morehouse School of Medicine just to orient you to where I am. Across the street is Spelman College. Down the street is Morehouse College. Further down the street is Clark College. So this is indeed the Atlanta University Center. But I'm very pleased to be here, very pleased to be a part of this and to certainly share with the outstanding panelists that you have in discussing such an important issue or issues as public health and racism. And if I could share the screen, I want to discuss sort of definitions, and I realize that there's nothing sacred about my definitions or anybody's, but there are some definitions that we sort of all agree with. One, of course, is public health. And I know that this may not be the definition that you use, but I think you would agree that when you get down to it, public health is what we do as a society, what we do together collectively to assure the conditions for people to be healthy. That's saying a lot. That's really saying a lot because assuring these conditions is not an easy thing to do. Now, I served on the World Health Organization's Commission on Social Determinants of Health. And we define social determinants of health, again, as the conditions in which people are born, reared, grow, establish themselves. The conditions are critical to good health. And public health deals with those conditions. And therefore, it's very important to the health of all people. The racism is a little bit more difficult to define, but I have to tell you a story. As a child in Anniston, Alabama, I became ill with whooping cough. You may have heard this story. But the only Black physician in Anniston was Dr. Jackson. And somehow my dad was able to get him to come out to the farm where we live to see me. And the story goes that Dr. Jackson was out there virtually all day. When he left, he wanted my parents to know that he didn't expect me to survive out the week, but that he had done the best that he could. You might say, well, why didn't they put you in the hospital? Well, there may have been a few reasons, but of course, back in that time in Alabama, being Black, I couldn't go to the hospital, like we couldn't do a lot of things. But I think the thing that really introduced me to racism, even though I didn't know the term at the time, was I was saving my money. This was after I had proven Dr. Jackson wrong and I had survived. And I was about 5 years old. And I was old enough now that I was going to walk to town with my brothers and other siblings. And when we went to town, I had saved my money. In fact, I had 5 cents, and I was going to buy an ice cream cone. So when we got to town, I slipped off from my brothers, went into the drugstore where they had ice cream, and asked for an ice cream cone. And the lady behind the counter said, "We don't serve your kind." She didn't say your kind, but I don't want to burden you with what she said. But basically, we don't serve you here. And I was only 5 years old, so I was really confused. Why don't they serve me? And of course, she used the word then, the one that starts with N. So it became clear to me that it had something to do with my race. And that may have been my first very clear experience with racism. There would be many more, but I will never forget that one. The interesting thing is, of course, is probably the most serious problem with racism was when I almost died at home with whooping cough and pneumonia and couldn't be admitted to the hospital. But I didn't know enough to realize anything about racism then. But when you refuse to sell me an ice cream cone and I've saved my money, racism becomes clear to me. That's an interesting sort of experience for Alabama. And if you read about Alabama, you know it's sort of the exemplary state for the days of racism. If I can have the next slide, some of you remember, the sit-in movement. I was a part of that as a student at Morehouse College. In fact, by the time I was a senior at Morehouse, I was the leader of the Atlanta University Center sit-in movement. And on one occasion, some of us, after getting arrested, went on a hunger strike. But the interesting thing is, of course, and what differs about my experience at Morehouse and my experience in Alabama is, number one, obviously I knew what racism was by that time, but also I went to Morehouse determined to confront racism. I wasn't comfortable confronting racism in Alabama. I didn't want my parents to be the victim of my actions. But when I got to Morehouse, in an environment that included students like Otis Moss and Marion Wright Ellerman and others, I felt very comfortable becoming a part of the student movement. And I probably don't have to say any more about the student movement. Many of you are familiar with that. But the slide in front of us, of course, entitled "A Ride to Freedom," this happened in my hometown. This is Anniston, Alabama. And when the Freedom Riders, there were about 300 of them in all, but when they went across the country challenging segregation laws by riding together on a bus, whites and blacks, what happened was in Anniston, my hometown, they confronted resistance, dangerous resistance. It's amazing that nobody died when those buses were burned. And they were burned in Anniston. I was home recently and they were celebrating the 60th anniversary of the Freedom Rides. So racism has been with us for a while. There have been some dramatic moments in the history of racism. And a lot of people, of course, didn't survive those dramatic moments. In Anniston, in Birmingham, the Freedom Riders went to all of these cities. They were challenged in all of them, but nowhere like Anniston, my hometown. That was where they burned the bus. So can you imagine what it was like going to college and when somebody asks you, "Where are you from?" And I said, "I'm from Anniston." And then when they didn't know where Anniston was, I'd say, "Well, that's where they burned the bus." And they would then appreciate where I was from. Well, I have several newspaper articles here in front of me, but I hope you recognize my good friend who's deceased now. John Lewis was also from Alabama. He was from Troy, Alabama. And as you know, John went on to become just an outstanding leader in government. And I used to, when I was president at Meharry and later Morehouse School of Medicine, I used to go to Washington, and I would go to John's office and take a nap on his sofa because he was such a nice guy. But he contributed so much. He died at the age of 80, which is a little over a year ago. And but we will always remember him for his outstanding leadership. And he challenged racism. Nobody can, as an individual, has challenged racism more than John Lewis. He was an associate of Dr. King's, of course. Next slide. I want to say a word about what we try to do here at the Morehouse School of Medicine and the Satcher Health Leadership Institute. If you are wondering how the institute got the name of Satcher Health Leadership Institute, well, when I left government, I came back to Morehouse because Lou Sullivan said they needed somebody to help them get a National Center for Primary Care. And that quote, if they could get a quote national leader, they could get $15 million. And so even though I had other plans, I came back to Morehouse. And sure enough, this building that I'm in now is the National Center for Primary Care. And I've had almost 20 years of great experience here, including having to serve as president, which I hadn't planned, but served as president for over 2 years. I only say that to say that leadership is important to me. It's been important in my life. I have often ended up in leadership roles without planning it that way. And that started, in case you're not aware of that started at King Drew. It was at Drew and that I took on these leadership roles early. And it was because people there thought that I had the ability to be a leader. And I was too young to know better. And so that's how I got started. But here at the Morehouse School of Medicine, we say that when you ask us, how do you decide who to accept in your program to become leaders? And we struggled with that question for a long time after we started our center. And after years, we settled on this statement: in order to eliminate disparities in health, we need leaders who care enough, know enough, will do enough, the courage to do enough, and are persistent enough to get the job done. So for us, leadership is about caring. It's about knowing. It's about doing what needs to be done and being persistent until the job is done. I've enjoyed the opportunity to serve as head of the Satcher Health Leadership Institute. I'm no longer head of it. I'm the senior advisor. Daniel Dawes heads the Satcher Health Leadership Institute. And in case you don't know Daniel, he wrote the book, Political Determinants of Public Health. Well, thank you for inviting me. It's great to be with you. I'm looking forward to listening to your presentations, and I am indeed honored to just be a part of this panel and look forward to hearing from each of you. Thank you.
Dr. Satcher. And I and all of us are looking forward to hearing more from you during this morning's panel discussion. I'd now like to introduce Dr. Kulini Gabreas, principal at Deloitte Consulting LLP, to offer remarks and to introduce our panelists.
Wonderful. Thank you so much, Dr. Carlisle, and thank you, Dr. Satcher, for such a moving and informative presentation. Speaking on behalf of Deloitte Consulting and more specifically Deloitte's Health Equity Institute, we are extremely excited to serve as co-sponsors for CDU's Leadership Summit to examine racism as a public health crisis and to explore strategies to advance health equity. As part of our commitment to this topic, my colleague, Dr. Asif Dar, and I published a piece focusing on racism as a public health crisis in September of 2020. In this piece, we emphasized that racism, not race, is often a root cause of poverty, homelessness, unemployment, poor nutrition, violence, and mental health concerns for BIPOC communities. We believe that recognizing racism as a public health crisis is one step towards moving towards health equity. We believe we can learn from past lessons to advance health equity. We believe we can use technology to elevate our level of awareness as individuals and to cultivate a shared social consciousness within our society. We believe this will foster collective empathy that allows us to activate and take a stand against the structural, institutional, environmental, and individual constructs that cause harm and perpetuate injustice toward Black and African American and communities of color. At Deloitte's Health Equity Institute, we define health equity as the fair and just opportunity for every individual to achieve their full potential in all aspects of health and well-being. We believe that health equity is an outcome that requires intentional and deliberate actions focused on creating sustainable and systemic change. So with that said, I am extremely excited to introduce our panel of distinguished guests who will help us examine racism as a public health crisis and explore strategies required to advance health equity. I'll begin with Dr. Asif Dar. Dr. Dar is Vice Chairman and U.S. Life Sciences and Healthcare Industry Leader for Deloitte. He leads the overall strategic direction for the life sciences and healthcare practices, including audit, consulting, tax, and advisory services. He's a respected futurist and a sought-after digital disruptor. Next, I'd like to introduce Dr. Sandra Hernandez. Dr. Hernandez is President and CEO of the California Healthcare Foundation. Prior to joining the foundation, Dr. Hernandez was the CEO of the San Francisco Foundation, which she led for 16 years. She previously served as the Director of Public Health for the City and County in San Francisco. She also chaired San Francisco's Universal Healthcare Council, which designed Healthy San Francisco, the first U.S. local government initiative geared towards providing care for all its constituents. Then I'd like to introduce Dr. Robert Ross. Dr. Ross is President and Chief Executive Officer for the California Endowment, a private statewide health foundation established in 1996 to address the needs of Californians. Prior to his appointment in July 2000, Dr. Ross served as Director of the Health and Human Services Agency for the County of San Diego from 1993 to 2000. Dr. Ross has an extensive background in health philanthropy as a public health administrator and as a clinician. As we jump in, I really want to also welcome Dr. Satcher to joining the panel discussion. I will tell you that I could have probably spent another 20 minutes describing the bios of our distinguished guests, but I wanted to make sure that we actually had enough time to hear their voices. And I thank you, Dr. Carlisle and CDU, for allowing us to be sponsors with you on this event.
Well, thank you, Dr. Ghebreyesus, and thank you to our esteemed panelists for joining us this morning. Let's go directly into our panel discussion, and we do have some questions for each of the panelists. And we'll start with Dr. Hernandez, Dr. Sandra Hernandez. Racial equity as an outcome. How can organizations use data to tell their stories more clearly and to advocate for additional support to provide health equity-centric services?
Well, good morning, David, and thank you for today's event and for all the sponsors. Dr. Satcher, for your extraordinary leadership over the years. It's a real pleasure to be here today. You know, David, as you know, the California Healthcare Foundation, statewide, private, independent philanthropic organization, very committed to using data as a method and a tool for informing systems, informing leaders, informing advocates, around, what the evidence actually shows. And as our speakers this morning have all mentioned, for decades and decades and decades, really for as long as we've collected data in the public health realm, these disparities are well documented in the data. But I think what we have learned over the years at California Healthcare Foundation is that you also need personal stories and individual stories and first voice stories, much as Dr. Satcher shared with us this morning. And so, over the last 5 years, in addition to data, we have tried to extract stories, both of things that are working in communities and leaders who are persistent and committed to this work, but also in doing polling that really helps lift up voices of folks that aren't historically in the conversation when it comes to policies or policymaking or regulations. And so we think it's both important to have data and also how you show data. I think there are ways to use data to draw wrong conclusions. And I'll give the concrete example. During this pandemic, a lot of literature on vaccine hesitancy in communities of color, in the Latinx community, and the Black community. And yet, if you actually talk with those communities and get their information, it's a lot more about access, and it's a lot more about being able to leave work to go get vaccine. And so I think, who controls the narrative is a lot of what both the data and the storytelling are important to recognize. And so I think that's been the biggest lesson we've learned at CHCF. Data is necessary, it's important, you need to be able to measure it. And even in creating measures, making sure those measures are measuring the right things. So measurement for measurement purpose is not adequate. And the last thing I'd say on this one point, David, is it's also important to put that data in the hands of communities themselves and to be able to make data actionable to advocates and folks who are trying to address these systemic racist policies that we're all familiar with. So that's how I sort of think about the data, the storytelling, the utility of the data, and the framing of the issues.
Well, thank you, Dr. Hernandez. And let's turn next to Dr. Robert Ross, President and CEO of the California Endowment, for our next question. Racial equity as an outcome. Determining the impact of meaningful changes in disparities across health outcomes, can be difficult. How do you quantitatively measure the advancement of health equity?
Yeah, thank you, David, just for your leadership at the incredible Charles Drew University. Thank you, Deloitte, for your partnership in supporting our colleagues at Charles Drew. And then to my sister, Sandra Hernandez, we've been in this fight together for a while. And then Dr. David Satcher's, he's our hero. I feel like even at my age, David Carlisle, I feel like a rookie on the field with Willie Mays or Henry Aaron on the same panel with Dr. Satcher. Yeah, so I'll give you the Cliff Notes version of our experience at the California Endowment. We're just putting the finishing touches on a 10-year Building Healthy Communities campaign, which was probably the largest privately funded frontal attack on the social determinants of health in the nation's history. We spent $1.5 billion, north of $1.5 billion over those 10 years. We identified 14 distressed, marginalized communities to partner with in those 10 years. And what we found and learned during that period of time is going back to Dr. Satcher's comments and the other comments that we've heard, what COVID reminded and affirmed us is how profoundly structural and systemic the issues are that through a racial equity lens and a racial injustice lens that impact health. And so you can't throw pilot projects at systems and structures. You've got to attack. If you're going to attack system and structures, you've got to attack them at their root. And unfortunately, and beautiful, Dr. David Satcher, his colleague, wrote a book about the politics of the social determinants of health. And those structures and policies and systems are inherently political in a white supremacy and racist draped history of this nation. And so I say that because the way we ended up funding most of our work in our attack on the social determinants of health through building healthy communities is through advocacy, organizing, voice, activism. When some of the photographs that you showed in the beautiful sort of video in the lead up to this panel were of people holding signs and using their voice. That's who we fund. Increasingly, we fund the activists and organizers because we've got to get at the structures, the policies, and the budgets to improve health. So we haven't been measuring hemoglobin A1Cs. We've been measuring what we call wins. Policy, system, and practice wins across those 14 sites. We documented 1,500 of them in that 10-year period. Some of them big, some of them smaller, from new skate parks for young people that the community demanded, from a much bigger win, such as a Health for All, where undocumented dreamers and young people won Medi-Cal coverage for the undocumented. Our money was in that fight, to school suspensions and school expulsions. Dr. Satcher is familiar with this phenomenon. The lack of mental health and behavioral health service supports in school settings allowed schools to use suspensions and expulsions as a way to improve the school climate, which was wrong and hurtful and harmful and criminalized those kids. So we funded advocacy efforts to reverse the school suspension and harsh discipline phenomenon and replace those policies and practices with restorative justice and behavioral health supports for kids. And school suspensions are down over 50% in the state of California over the last 10 years because of that work. So that's what we've been funding and measuring. What are the policy, practice, and system wins through a racial equity lens that, back to John Lewis again, Dr. Satcher, what he called the good troublemakers.
Yes.
We are supporting the good troublemakers, those who take on these systems and policies front on and through a racial equity and racial justice lens.
So thank you, Dr. Ross, and looking forward to your next statement and response as well. Let's move on to Dr. Asif Dar, and we'll ask our first question. Racial equity as an outcome. Deloitte published a racism as public health piece in September. What about racism itself? What about racism itself makes it a determinant of health outcomes? And why did you create your own Health Equity Institute?
Well, starting off, Dr. Carlisle, thank you for inviting me. Dr. Satcher, you are a collective hero. And to my distinguished other panelists, it's a real privilege and honor. Let's start at the top. Racism, not race, is a root cause often of homelessness, poverty, unemployment, poor nutrition, violence, and mental health concerns for Black Americans and people of color in the United States. Racism was not dismantled at the end of slavery, as everybody here knows well. Laws and systems put in place after the Civil War made it difficult for Black Americans to own property and accumulate wealth, and state and local statutes denied Black Americans many opportunities, including the right to vote. And despite the very powerful description and stories that we just heard from Dr. Satcher, the civil rights movement in the 50s and 60s, to achieve equal rights for Black Americans under the law, disparities and racism continue in several forms. Unequal access to medical care has led to poor outcomes for many Black Americans. But however, limited access to the quality education, jobs with good pay, healthy food, and safe housing can have even more profound impact. And some studies estimate that these non-medical drivers of health, Dr. Satcher referred to as social determinants of health, can account for perhaps even 80% of a person's overall health outcomes. In addition to the issues of physical safety and security caused by racism, research indicates that racism itself may increase chronic inflammation and the risk of chronic illness. For instance, the American Heart Association published data indicating that experience with racism, even after adjusting for age, gender, hypertensive risk factors, can lead to high blood pressure. And a meta-analysis of data shows a strong link between racism and poor mental and health outcomes. We just heard from Dr. Ross the powerful impact that the pandemic has had, and more importantly, the powerful nature into which it's ripped off the covers of many of our eyes in terms of the profound impact that racism has to overall health outcomes. And what we started appreciating is that there was a need for actors who wanted to come together, who wanted to better appreciate the opportunities to work together, to develop a clear architecture for action. Given the numerous factors that I just discussed and that we just heard, the question is, what's the blueprint? If one wanted to make a historic improvement in cardiovascular outcomes or intermediate outcomes that precede it, like obesity, or the causes of it, like poor nutrition and access to jobs, the question is, what's the blueprint for actors across the ecosystem of financial services, community organizers, governmental actors, healthcare institutions, health provider institutions, health plans, and life science organizations coming together? That new blueprint required catalytical action and change. We've been involved in doing work in this space for a while, and our Center for Health Solutions was doing research. But the type of action required was different. And to convene action, publish data, help determine what worked and didn't, and let it out into the world, in our mind, was a domino to create action amongst many actors. So that's why we had to move in and frankly, do our part.
Well, thank you, Dr. Dar. And next we'll turn to Dr. Satcher. And our first question is with regard to equitable policies and systems. How do we leverage policy to dismantle the history of racist policies and systems while also pushing forward to drive progress?
Well, that's such an important question. And I'm not going to be able to do it justice in terms of my answer. But I don't know how many of you have dealt with the McKinley model, which is it's sort of a three-dimensional model. And upstream, it deals with things like policy, what happens in Congress or the state legislature. It's the upstream action that ends up with policy. We've had a lot of experience with that. A good friend of mine is Patrick Kennedy, and I had some experience with his father and uncle way back in the days when we were sent to prison for trying to eat in a restaurant in Atlanta. But it was Patrick Kennedy who introduced legislation related to mental health policy and basically pushing for mental illness to be dealt with the same or even better than we did other health problems. And it was a policy issue, and we're still struggling with that because we live in a country where it might well be that 40 states will agree to something, and then 10 will not. So the whole policy issue is big. You can't totally separate it from other things related to what we do as a society. But we send people to Washington to lead us in making policy. Sometimes that works quite well. Obama intended for what they call Obamacare, and I don't think he minds that anymore. He intended for it to be a way of providing access to health care for everybody. But as you know, whereas most states now are required to to offer mental health service at the same level as other health services. There are still, I think maybe 13 or more states that do not provide the equal access to mental health service. That's a very serious problem, but it's policy. And how do we change policy, and how do we change it in such a way that it impacts everybody? So each of us, regardless of what our role is in this whole struggle, we must be concerned about policy. How do we do a better job of making policy? How do we do a better job of changing policy when that policy needs to be changed? And Washington is an interesting place. I can tell you that, having spent time there. But that's where policy gets made at the highest level. But it's a struggle. And I'm not just talking about January 6th. It's an ongoing struggle to get the kind of policies that we need just to provide decent health care for everybody.
Well, wonderful, excellent answer. It was a difficult question, and we could discuss this issue for hours, certainly. Well, let's come back to Dr. Sandra Hernandez. And Dr. Hernandez, again, speaking about human-centered public health, what actions will lead to sustainable impact for the communities we serve? And where can that impact be multiplied and scaled?
Yeah, it's a great question. And, you know, I might go back to something that Dr. Satcher said about public health. And there's really two components to it that I think are relevant to that question, David. One is that public health, by definition, does need to be interdisciplinary. It is all of the dimensions that lead to health and healthy opportunities really do require that we take a very interdisciplinary approach to addressing these systemic issues that we're facing. And I would also offer that you know, there's a tenet in medicine: first, do no harm. The corollary tenet in public health is don't try to solve anybody's problem without having them actually define the problem and help you develop the solutions. That was sort of lesson 101 when I first became director of health here in San Francisco during the HIV epidemic. And all kinds of folks would have ideas about how we should go about addressing that epidemic in the early years. But what was really important was to sit down with the folks that you were actually trying to work these solutions with, to try to design those programs and policies and activities that actually were going to have the biggest impact. And I think we often get stakeholders at the table, and we define those stakeholders by virtue of whatever position of power or influence they might have: health plans, delivery systems, IPAs, et cetera. But really, the premise of a human-centered public health approach really does start with, first of all, I would argue, what are the assets that we have in communities? We tend to design everything around a problem and not look at the inherent assets, natural leaders, natural voices that exist in all of these communities because of resilience and because of persistence and because of leadership programs and programs like CDU runs. And so in many ways, I think the issue here is, you know, don't try to solve any problem. Bob talked about this as well. Well, any public health problem, these are a requirement that you bring all kinds of folks together. During the HIV epidemic, when we were here in San Francisco, there was good evidence that if we could do needle exchange, we could interrupt heterosexual transmission of HIV. And yet this was in the middle of a large drug problem that we had in various parts of our communities. And you know, you're the health officer, you run the AIDS office, and you say, you know, this is an intervention that could save lives, but that alone does not allow you to step forward and run a needle exchange program. You actually have to bring, you know, the faith-based leaders and folks that needed to understand the same kind of data and information that we were getting from Europe and elsewhere, and they needed to help us implement those kinds of programs. So I think we need to assess the assets. We got to take an assets view of this, because there are natural leaders and those solutions exist within communities. And this concept of human-centered design public health really is just trying to draw those principles into play in order to have successful interventions from a public health point of view. We make a mistake of training people without good peripheral vision. We tend to train people in silos, and people then think that that silo is the solution to these very systemic and interrelated racially oriented discriminatory policies. And I think in trying to apply what we've learned is start with assets and recognize that you can't solve any of those problems if they're not framed from the point of view of the populations you're trying to reach.
Well, thank you, Dr. Hernandez. And those are words of wisdom from a experienced public health practitioner and government official as well. Let's go back to Bob Ross. But before we go back to Dr. Ross, we have a little words for our audience, which is to remember that you can participate in today's discussion. Please share your experience here today on social media by using the hashtag CDU Leadership Summit. You can ask our panelists a question also via the chat function. So go ahead and think about questions that you might want to submit and go ahead and send them in. We'll be getting to those questions in just a few minutes. But let me ask Dr. Ross, based on your experience in California, what are the strategies that have been used effectively to strengthen collaboration and reduce silos between organizations involved in health equity? Are there key lessons that we should speak about at this session?
Yeah, thanks, David. I'm going to build from the comments of my sister, Dr. Sandra Hernandez, on this. So I mentioned earlier we spent more than $1.5 billion over 10 years to learn about addressing the social determinants of health and through a racial equity lens. So I'm going to give you all for free what we just spent $1.5 billion to learn. And the theory of change as a result of that work is A plus B equals C, where A stands for agency, meaning individual and collective power and voice. B stands for belonging, the spirit and the ethos of inclusion that we heard going back to Dr. Martin Luther King and John Lewis, the beloved community. And A plus B equals C, and C is change. You heard from Dr. Satcher how these racially mediated disparities are about conditions. And so we found that when we trust people's agency and invest in it and trust in the spirit of belonging and coalition building and alliance building, building on Dr. Hernandez's comment about public health, Sun Tzu in The Art of War says, when confronting a great enemy, don't go alone. Bring your assets, but build your partners. And so the short answer to your question, David, is, and this is the hardest thing to do. And I know Sandra and David Satcher well enough to know that they would agree with this from their public health leadership roles. The hardest thing the easiest thing to say, but the hardest thing to do is to center the experiences and the wisdom of those most impacted by the health injustice and the structures, those who are on the receiving end of health injustice. If you center their experience and listen to them and engage them about the strategies moved forward, that's the easiest thing to say and the hardest thing to do, right? Brian Stevenson, the great Brian Stevenson from the Equal Justice Initiative, talks about this in his writings and his speeches, the importance of being proximate to the pain and vulnerability of injustice, right? And so for us, we talk about community engagement. It's a harder thing to execute and live up to. When I'll just give you just two really quick examples. I know we're short on time here. about 12 years ago, I went to visit. I did a site visit of a program we fund, a very grassroots organization called the Youth Justice Coalition in South Central Los Angeles. And they it's a grassroots organization run by, still to this day, run by young people, many of whom were formerly incarcerated or formerly in the foster care system. And they do both services for young people trying to move on from the juvenile justice system and reintegrate into their communities, as well as advocacy support. And the vision they shared with me at that time, and that was 12 years ago, David, was their vision for juvenile justice reform was not simply to provide more mental health services in the detention facilities. Their vision was no young child, no young person should be in lockup in the first place. They had an abolitionist view of juvenile justice and why is it in this great nation that we are housing young people in locked facilities in the first place. They should be served in their communities with community-based systems of care, and we should be closing youth prisons, right? And so we funded their work, and they ran their own campaign called Schools Not Prisons. And that's an example of transformative system thinking, not incremental, not gradual, but transformative thinking, that we can serve these young people and make communities safer without putting children in lockup, right? And I got to tell you, Dr. David Satcher, 12 years later, these young people are doing it. They're moving it. They have convinced the County Board of Supervisors here in Los Angeles to begin closing down youth detention facilities and replacing them. It took a while. It takes more than a minute, right? And this is another thing about another experience in terms of engaging in social determinants of health. The smartest thing we did, and I'll end on this point, was we asked our board of directors to give us 10 years. We needed every year of those 10 years, David. We needed every year of those 10 years, Dr. Satcher, because many of the wins that I referred to earlier didn't start showing up until year 3, year 4, year 5, year 7, because it does take time when you're confronting structural change. It doesn't happen in a 1-year grant window, right? This is not, just measuring hemoglobin A1C after you change somebody's diet for a year, right? So that's my point is to center the experiences of impacted people and see them not just as victims, but as architects for systemic change.
Well, thank you so much, of course, once again, Dr. Ross. A reminder to our audience, you can submit questions via the chat. We're looking forward to getting those questions. Let's go back now to Dr. Asif Dar with a question on the topic of human-centered public health. What have we learned around vaccination in the United States that teaches us about micro-targeting the interventions around other public health crises? Dr. Dar.
Yeah, there are two things that I wanted to bring up. I know we don't have a lot of time, and want to build on some of the comments that Dr. Hernandez and Dr. Ross just made. The first is a concept that I refer to as precision public health, that individuals and individual communities tend to have very specific needs, and by using data and looking at the variety of factors that we can now look at, we can actually create precision public health campaigns. I'll give you a quick example. For instance, if you just physically moved a vaccination site near a community that needed vaccinations, you may not address all of the needs that are required to overcome some concerns with getting vaccinations. For instance, in certain locations, if you make sure that there's plenty of parking, but not plenty of easy to get public transportation that people need for transfers and 2 miles of walking, the likelihood that they'll get vaccinated drops significantly. And it's quite straightforward because, and actually what we're trying to do is to create equity. The challenge of a lot of these discussions is equality doesn't lead to equity. If an individual is working 2 to 3 jobs, the idea of them taking an entire day off doesn't mean the same thing for a person, frankly, in some of our position. It's just a completely different story. So looking at parking, looking physically at the layout of the facility, where security is kept, the representation of the vaccinators, the pre-work to provide or disinfecting misinformation channels in advance of the site opening up. All of these factors, if you layer them on, can bring resources where people want and need them. I really was inspired, Dr. Ross, by your comments about what people, bringing them into the discussion. Both you and Dr. Hernandez talk about bringing them into the discussion. That's what we need. We need to pull people into the discussion because nobody wants to be unwell. The majority of human beings want to be well if we simply get them involved in the conversation, use the data and the resources, and provide precision answers to that. And that's what I refer to often as precision public health.
David, you're on mute.
Just about out of time, and a last question for Dr. Satcher, our keynote speaker. And this is kind of a question, a free-form question for you. What message would you like us to take away from this panel this morning as we reflect on the messages of our various panelists and their expertise?
Well, that's a tough one. There's some really important messages, and I won't do justice to them. But clearly, public health is more important than we think, I believe. Because when you define public health as being a collective effort of people coming together, finding each other, and I think both Dr. Hernandez and Bob Ross have done a good job of discussing how we have to engage people, engage with them in trying to change their situation, and we don't do that very well. So I think public, the most important word, and I know I use different words, and they probably mean the same thing, but collective. When people find each other, in order to have good public health, people have to find each other and then try to work together to improve their situation. That's public health at its best, really. Bringing the resources together and applying them to some of our most difficult problems. One of the best experiences I had as director of the CDC between 1993 and 1999, of course, related to the fact that, number one, we had eradicated smallpox disease. When I say we, I was not a part of the CDC when smallpox was eradicated. So, but under the leadership of the CDC and the World Health Organization, we collectively had eradicated smallpox. Now, we haven't eradicated the disease since then. And I had this great idea that, we were going to eradicate polio. I didn't see any reason why we couldn't. We had the vaccine, and we had the tremendous experience with smallpox. And I believe at the time there were only 3 or 4 countries where polio had not been eliminated, and I'm being very careful with these terms. Eradicated means the disease does not exist anywhere in the world, and that's smallpox. It's the only disease we've eradicated. Polio means that we've eliminated it in the United States, for example. We've eliminated polio. But we are that close, very close to eradicating polio. In fact, I believe there are only 2 or 3 countries left. Afghanistan, Pakistan, Nigeria from time to time, but we may have eliminated that problem. But why is it that we have not eliminated polio in Afghanistan and Pakistan? Because of fighting, because of the war. And one of the greatest barriers to progress in public health now is when people don't get along. Not only do they not work together, they don't get along and they're shooting at each other, trying to eradicate each other rather than being able to aim at diseases. So we couldn't immunize children in Afghanistan because too many bullets flying all over the place. And so a lot of the problems we have in quote public health is due to the fact that people are trying to harm each other in order, as opposed to doing each other good. So it's interesting. I hope that one day soon now we will eradicate polio. Africa celebrated last year because they had basically eliminated polio in Africa. But Afghanistan and Pakistan still have cases. And again, it's mainly because of the fighting going on in those countries. So isn't it interesting that in order to be successful in eradicating the disease, we first have to find a way to stop fighting each other? I'm saying that because it's consistent with what I think Dr. Hernandez and Ross and others said in this panel. We've got to work with people where they are and to try to move forward and improve all of our situations. Probably didn't answer your question, but what the heck.
Well, Dr. Satcher, I think any pearls of wisdom that you have on that topic are an appropriate answer to that question. So thank you very much. I appreciate it. And thank you to each of our panelists, our esteemed panelists, Dr. Sandra Hernandez, Dr. Robert Ross, and Dr. Asif Dar for being with us this morning. Let's see, do we have, I think it's time to hear from our audience and their questions if we have any. Last I checked, there were none. Okay, no public questions. And I think we may be able to get people to lunch a little bit early here. Let me say, this is a topic that we could easily spend the rest of the day talking about. But as we come to a close, on behalf of CDU students, alumni, Board of Trustees, faculty and staff, I want to sincerely thank you all for a thoughtful morning of conversation. The 2021 CDU Leadership Summit on Health Equity and Social Justice is made possible through the generous support of our sponsors and partners. Thank you to our presenting sponsor, Blue Shield of California Promise Health Plan. Thank you to our co-presenting sponsors, Deloitte Consulting LLP, Martin Luther King Community Hospital, and Torrey Pines Bank. To our corporate sponsors, Hologic, Pfizer, the Southern California Gas Company, AOE Consulting, Arena Pharmaceuticals, the SLAM Collaborative, Children's Hospital Los Angeles, HealthNet, and Anastasia of Beverly Hills. Our President's Friend sponsors, Diane and Scott Weingarten and family, and LA Care Health Plan. Our virtual table sponsors, Gallagher, the Tessie Cleveland Community Service Center, US Bank, Anderson Barker Architects, the UCLA David Geffen School of Medicine, the UCLA School of Nursing, Angela Minifield, Dr. Diane Breckenridge, Sylvia Drew Ivy, Steve Michael, Compton College, Dr. Javad Gama, Vice President Carl McLaney, and the American University of Health Sciences. And to everyone who joined us today, thank you very much. Charles R. Drew University of Medicine and Science is a higher education institution founded on the notion of attaining health equity regardless of a person's skin color or zip code. CDU is committed to doing what we can to eradicate disparities. I hope that today's conversation introduced the audience to fresh perspectives that I hope will encourage more meaningful change in the nearby future. Please plan to join us on Thursday, September 23rd for the next Leadership Summit, where we'll discuss racial equity and social justice. What are the obligations and responsibilities of corporations today? For more information, visit us at www.cdru.edu. And thank you for joining us.
you.